So our first complication of cirrhosis is portal hypertension. So portal hypertension is one of our major complications, and it itself has complications of itself. So you have cirrhosis, that's a complication of, let's say, Hep C, and then of that complication you have portal hypertension, and of that complication you have further complications such as varices, right? Which we talked about in detail in GI. So it's like complication of complication of complication. So it gets a little bit hairy here and there. Not as hairy as a liver patient because they have decreased hair throughout their body. All right, so portal hypertension. So what's going on with portal hypertension? The blood pressure up top, or I should say the pressure up top in the CVP is just fine. All right, 4 to 6, 6 to 8, depending on what source you look at. The pressure up here is perfectly fine. What's going on is we deliver blood to the GI tract, and that blood should then nicely flow right back up into the inferior vena cava via the hepatic vein. But in cirrhosis, they have a cirrhotic liver. They have a scarred liver, or not a scared liver, but a scarred liver, right? That's very, very scarred, and therefore blood cannot easily go back into the central circulation, right? So all that blood backs up, right? It backs up a little bit. It's getting upset. It's like, well, how do we get forward? And how's it going to get forward? It's going to say, I'm going to vasodilate that liver. Watch me, right? It's going to release little vasodilators that are going to try to vasodilate the liver, but what's going to happen is it vasodilates itself, right? And that then allows more blood to be deposited inside the veins, and that's going to lead to more complications, unfortunately, right? And those little vasodilators will get through, but not as intended, and that can lead to low flows to the kidney and systemic hypotension, right? So the circulating vasodilators and low BP can develop because of a portal hypertension, the complication of it. Okay, so lack of forward blood flow occurs, right? It could be cirrhosis, the most common, but it could be just a clot that forms. A clot in the hepatic vein, could be a clot in the portal circulation. Like we showed you liver flukes twice, right? So those could be reasons they can make their way up the biliary tree. Not so much liver flukes, but like schistosomiasis could go up there. There's other different reasons why you could have portal hypertension. But the most common in America, especially, is someone that has a cirrhotic disease from alcohol or fat or Hep B, Hep C, etc. Okay, so we get cirrhosis. We've got vasodilators that try to help things, but it's ineffective, and it starts swelling the veins in the portal circulation, which makes it fill up with more blood, and that blood is albumin poor, right? Why is it albumin poor? Because the liver can also not be making albumin, and now all the fluid is going to start leaking out into the abdominal space, which has the most blood volume because of portal hypertension. So that leads to ascites, and ascites we're going to talk about by itself as well, right? But ascites is because of low albumin and the portal hypertension, and we got leakage of this fluid into the belly. And how do you fix that? You got to take the fluid out, right, with paracentesis. And usually you're going to be replacing albumin in most cirrhotic complications. Right, hepatorenal syndrome, we're giving albumin as well, right? Albumin also is for hepatorenal syndrome. Variceal bleed, we don't give fluids, right? We know with variceal bleeds, they're bleeding because this area is all full of fluid, and once you poke a hole in a gastric varice or an esophageal varice, it's going to bleed really, really fast, right? So giving albumin, giving saline, giving LR, giving blood products itself, giving FFP, because we know they're coagulopathic, is going to have worse outcomes, right? So the priority to these patients that have variceal bleeds is to do what? Control the bleed is a very good answer. Yes. How would you control the bleeding? With a GI doctor, right? And GI doctors are going to come with a scope, right? They're going to scope with an EGD, right? They're going to go in there, going to band the varices to stop them from bleeding, right? We don't want to put more volume into that portal circulation, because you give more volume, right? Whether it be central vein or peripheral vein, right? When we give more volume, all that's going to do is just going to fill up this circulation more, and it's going to bleed even more, right? So that's not the idea. The idea is to do a scope as soon as possible. Do NG tubes make varices break? No, there's no evidence that happens, but these engorged varices will bleed extensively, and they bleed because of usually the underlying SIRS process, an underlying sepsis or pancreatitis or even gallbladder situation. Okay, so this widespread inflammation, bacterial infection is what causes someone to lead to a variceal bleed. The bleeding is immense, and we have to fix it as soon as possible. Okay, EGD is a priority. In the meantime, we can transfuse to get the blood pressure up to like 100 maybe, but we're definitely not going to make them hypertensive, and we're definitely going to try to get GI in there as soon as possible. Okay, so other complications of portal hypertension, we'll talk about hepatopulmonary syndrome. We'll talk about cardiomyopathy that happens because of portal hypertension, and other complications down the road, right? So we'll spend a little bit of time on these as well, especially splenomegaly. So all this extra pressure inside the portal circulation, well, there's a spleen nearby, right? The spleen is going to get swollen with blood. And when the spleen gets swollen with blood, it thinks that something's going on. It thinks like a serious bleed is happening, and it's going to start holding on to more blood, and it's going to start, holding on to more platelets, and it's going to make your platelets low. That's not going to help someone who's bleeding, and that's not going to help someone that is at risk for bruising and other consequences. Okay, so we'll talk about that coming up. But again, the idea with portal hypertension, if they have a variceal bleed, fix it right away. The other thing we want to do is give beta blockers, right? So non-selective beta blockers are used to, not make the blood go to the GI tract, right? We're going to dilate out the skin, right? Dilate out the renals and let all the blood go there instead of the portal circulation. Also, we have little alpha receptors on our liver itself, so it's going to open up that a little bit and allow some of the blood to make its way from point A to point B. Okay, so non-selective beta blockers are indicated as well. Right, so that'd be like your carvedilol or your propranolol. Okay, so that's the idea behind portal hypertension. So hepatorenal syndrome. So HRS, hepatorenal syndrome, happens as a complication because of portal hypertension. As we learned, portal hypertension releases vasodilators to try to open up the liver so that it can get through. Right, so all these vasodilators being made, nitric oxide, prostaglandins, other splanchnic vasodilators, right, splanchnic being the gut, right, are trying to vasodilate the liver, but they only vasodilate themselves, so the vasodilators don't make it through 100%. Some of them do though, like a little percentage of them do, and they start vasodilating everything else. That will work, but it actually lowers blood pressure overall, and then the kidneys get what? They get upset, right? So they are going to get a pre-renal failure, and we need to try to restore that as best we can, right? And vasopressors are usually low threshold. We're gonna say, oh, do we need to start pressors or no, right? And we are going to start a PO pressor, right? The only PO pressor that we have around by mouth is midodrine, right? Midodrine will get started right away. We're also going to cause splanchnic vasoconstriction overall, right? Same medication we gave for GI bleeds. When they're bleeding and bleeding and bleeding, we give a splanchnic vasoconstrictor to shut down the GI tract. What medication was that? Octreotide, right? So that's also part of the therapy for HRS, right? So get ahead of myself. On the next slide, we'll talk about the treatment, right? But basically, we have portal hypertension. Vasodilator are trying to compensate, and then we're going to try to release the SNS. The SNS is going to fire off, the RAS is going to fire off, ADH is going to fire off. All that's going to do is going to raise volume, and that's just going to cause all the volume to go to the portal circulation. And unfortunately, it's not going to correct the liver, the underlying renal failure, right? And this poor BP to the kidneys is what's going to cause renal failure, and that will then definitely be present to someone with end-stage cirrhosis, right? If it doesn't happen early on in the disease course, it will progress, and that's usually the pathway for someone who has end-stage cirrhosis, right? And what causes someone to, just like with CHF, right? It could be they forgot their medications, they have an acute illness of some sort, they have an MI of some sort, but with that made someone go with CHF exacerbation. Same thing with renal failure or with liver failure, right? Liver cirrhotic patients, right? Do they get an nephrotoxin and they have liver cirrhosis? Well, the patient was already at risk with low blood pressure, and you add an nephrotoxin on top of that, that's going to throw them over the edge to have the kidneys start failing, right? And I should kind of preface this that hepatorenal syndrome is just the liver causing it. Do these things also make your kidneys not work? Yes, and that's the idea, is to try to figure out what's causing it, because we know they're high risk for renal failure. We got to stop the underlying precipitants of renal failure to begin with. because hepatorenal syndrome is a diagnosis of exclusion. That means you ruled out everything else and it's only just the liver's fault, right? In the meantime, we have to say, well, you got a GI bleed and now you got a low BP hemorrhagic shock situation. It's like, was the liver's fault? Yeah, but was it because of their vasodilators they released? No, it was that's something we can try to reverse right away. We can stop nephrotoxins. We can stop excessive diarrhea. And why would someone with liver failure have excessive diarrhea? Because we gave them lactulose, right, for hepatic encephalopathy. So usually if someone has hepatorenal syndrome, it's like, oh, we're off the books for liver or lactulose right now. We're going to try to get you resuscitated. We're going to try to get, take away all the underlying problems that could cause renal dysfunction, and we're going to try to support your pressure, and hopefully we get your kidneys bounced back up the way they should be. Okay, so infection puts you at risk for GI bleed. It also puts you at risk for hepatic encephalopathy. Right, so that's like a catch-22. If someone has a infection, now they're at risk for GI bleed, variceal bleed, and they're also at risk for hepatic encephalopathy. And they need lactulose for hepatic encephalopathy. But if you give lactulose, they're going to have renal failure. Which one do I do, right? So that's why it's a very, very delicate balance with patients that have liver disease, right? So we need to fix the infection. How do you fix the infection? Just give antibiotics, right? Give antibiotics and hope for the best, support their blood pressure, and hopefully we get them over this infection and hopefully fix any kind of variceal bleed that might happen. And hepatic encephalopathy, we'll give lactulose eventually once we don't have the diarrhea that may have caused the renal dysfunction in the first place. Okay, so patients that have ascites, one of the fixes for ascites, as we'll come to learn, is doing large volume paracentesis. Well, large volume sounds like extra steps for low blood pressure, right? So if I take out a large volume out of their belly, more fluid will then fill up that belly, and now I'm at risk for low blood pressure, and that could cause my renal failure. So we have to restore the volume, and we have to fix the underlying cause, and then once all that's fixed and the renal failure is gone, then it wasn't hepatorenal syndrome. But if the renal failure is still there, it's hepatorenal. Right? Just as bad as volume underload or volume depletion is volume overload, right? Volume overload puts extra stress on the kidneys, right? All this extra stress, all this extra CVP, putting all this stress on the kidneys is going to cause the kidneys to fail, right? So it could be heart failure, it could be fluid overload for someone that comes in septic, right? And they have liver cirrhosis, and now they have, they're high risk of their kidneys be decompensating as well. Okay, so we have to avoid volume overload not only with renal patients and heart patients. It's a good idea for liver patients as well, because giving more volume to them is going to worsen their portal hypertension, as we know, but it also can put more pressure on the kidneys. Okay, and then increased volume, we know is going to increase intra-abdominal pressure, but just increased intra-abdominal pressure can also be present because they have tense ascites. They have ascites that needs to be tapped, needs to have a large volume paracentesis. So it's like, which one are we going to do, right? You can imagine we're kind of dancing in eggshells right now. Okay, and then just straight up the deterioration of the liver function. So liver function is getting worse. The portal hypertension is getting worse because they're not making albumin. That could put you at risk of your kidneys failing, right? But again, this is a diagnosis of exclusions. That means everything else above is gone, fixed, and now they still have creatinine elevation. They still have oliguria. That is someone that has a Hersaki. They have a hepatorenal syndrome acute kidney injury variant, right? So it's just a creatinine elevation and everything else is fixed. That is what hepatorenal syndrome is, okay? So creatinine is going to be below a baseline because patients with cirrhosis have decreased muscle mass. They are usually malnourished. They don't have a great intake. They really don't feel great all the time. They have this huge ascites. It's tough to get around. So they're going to have a poor muscle mass to begin with. Their creatinine sits at 0.2, 0.3, right? Because muscles, at a constant rate, muscles secrete creatinine, a waste product, right? And our kidneys get rid of that waste product at a significant rate, right? Or at a steady rate, I should say. Okay, so these guys have a creatinine of 0.2, 0.3. And as we'll learn with acute kidney injury, you look for a 1.5x change or a 2x change or a 3x change in the creatinine. So if it's 0.3, a 3x change would be what? 0.3 times 3 is 0.9. And in 0.9, you're not going to bat an eye at, right? That's less than 1.2, we're fine, right? But that's a huge change for someone with liver dysfunction, right? So you always look at the percent change, right? Or the multiplier change, the 1.5, 2x, or 3x change in our creatinine. Okay, so 0.3 to 1 is a huge deal, right? 1.0 is fine, right? They come in and they get admit labs from ER, creatinine is 1.0, it's no big deal. But if they were here 3 months ago and you look 3 months ago, their creatinine was 0.2, 0.3, that is acute kidney injury. That is a damage to their kidneys. And we got to figure out, are they here because of all this other stuff that may have precipitated kidney failure, or is all that stuff negative and they're just coming in because of hepatorenal syndrome? Okay, which is usually because of a low blood pressure because of the vasodilators that are sneaking across the liver. Okay, so there's no evidence of other causes. Now you have a hepatorenal syndrome. Are we going to potentiate those other causes? No, we're going to not give them NSAIDs. That's not great. As we'll learn with acute kidney injury, NSAIDs are going to be hazardous to kidneys and going to make people go into kidney failure more. That's why we don't do NSAIDs in the ICU for A, for heart problems, and also B, for kidney problems. Okay, so how do you know someone has hepatorenal syndrome? They have hepato problems. So they have cirrhosis, right? So we know that's the underlying cause. So they have, if they don't have cirrhosis, it's not hepatorenal. That doesn't make sense, right? So the renal ultrasound also is normal. So they don't have like a diabetic nephropathy. That's the diabetes caused it. It wasn't the kidney. That wasn't the liver that caused it, right? They don't have hypertensive or hypertensive nephropathy. It wasn't the kidneys just get destroyed because of high blood pressure. It was because of the liver. Okay, so the renal ultrasound can let us know that. We do a renal ultrasound on their kidneys, and you're going to look to see do they have normal kidneys or do they have shriveled up kidneys with chronic kidney disease, right? Little prunes. So that's going to tell you, oh, you have diabetes or hypertension that probably caused your kidney disease. It wasn't your liver. Okay, and of course the shock needs to be fixed. That's going to help us determine that it wasn't like septic shock, it wasn't cardiogenic shock, it wasn't neurogenic shock, it wasn't hypovolemic shock or hemorrhagic shock because of varices. So we fixed the shock state. Okay, that's the idea behind HRS or hepatorenal syndrome. Okay, so we have all these little vasodilators from portal hypertension, all these the vasodilators are leaking across, and that's going to cause a lack of flow to the kidneys, and that's going to ultimately lead to hepatorenal syndrome. So how do you fix it? So the fix, like I mentioned, is you're going to give them the best shot. You're going to try to fix the underlying problem, which is always the right answer, right? So you got a kidney disease. Let's fix the underlying problem. Well, the underlying problem, like I mentioned in the previous slide, right? You do an EGD for variceal bleed. You fix spontaneous bacterial peritonitis from ascites. You fix the large volume paracentesis, hypovolemia with albumin. So there's all kinds of things we're going to fix in the meantime. But how do we fix the hepatorenal syndrome also? Just because we're not going to wait 2 days. Because if you look at the previous slide, it was 2 days of the creatinine is still elevated. So in the 2 days, we're not just going to wait it out. We're going to load them up with albumin to begin with. Right, it's usually a high dose for 2 days, about 1 gram per kilogram. Right, so if they weigh 80 kilos, right, so they're getting 80 grams of albumin, right, and that's 25%. If you do 5% albumin, like this one right here, that's going to be a lot of volume, and all the extra volume, the other 95%, is just going to go into the portal circulation, right? So usually 25% is what we're going to be using. So 25% albumin is the goal, or the amount that we're going to give. So we're going to give 80 grams. So that's 3 bottles at least of 25 grams of albumin, right? So you're giving 3 bottles on the first day, 3 bottles on the second day. And then after that, we'll give about 20 to 40 grams. So one bottle or maybe 2 bottles, okay? And that's pretty much until we get a resolution of their kidney failure, hopefully. And of course, simultaneously, we're trying to fix all the other problems that could be causing kidney dysfunction, okay? So we support the blood pressure, right? We don't give them fluid because that's going to worsen portal hypertension, right? Beta blockers are great for portal hypertension beforehand, but once someone develops portal hypertension or someone develops a variceal bleed for that, or not variceal bleed, but portal hypertension, spontaneous bacterial peritonitis, SBP, or they develop HRS, beta blockers are no more, right? So beta blockers, so no more with, with HRS, or with SBP. Those are once someone develops that in their lifetime, you don't get non-selective beta blockers anymore. Okay, that's perfectly legible. Stop laughing at me. All right, so that's the idea. So you have a beta blockers are no more because beta blockers, they're non-selective ones. Those are going to lower your blood pressure more, and that's going to worsen someone's renal function. right? And not giving fluids, we're giving albumin, right? And when we talk about renal, when we talk about fluids, they're like, oh, you should give albumin. It's better than normal saline, or it's better than LR. Well, there's actually no difference. They're exactly equivalent in mortality and efficacy and everything. It's just the only difference is the albumin costs about $100 more than a bag of saline or LR or even plasma light. So, the only time you should see albumin is, you might see some fancy doctors come in, and they're like, they pull up in their Porsche, and they're like, oh yeah, and albumin bottles are going to empty out of their car as they open the door, right? And then they come in and give all their patients albumin. Cool. That's not, if they want to pay it, that's fine. But with a patient that actually needs albumin, that's going to be this patient right here with hepatorenal syndrome, right? The albumin's being given because it's going to pull fluid into the vascular space, right? And that's going to restore blood volume, hopefully, to the kidneys. Okay, and hopefully take it away from the ascites. Okay, so we give beta blocker, we stop beta blockers, give albumin, and we stop any kind of nephrotoxins, any antibiotics or NSAIDs. What kind of antibiotics might cause nephrotoxicity? Vanco is a good one. Aminoglycosides are another one, right? So aminoglycosides are known as GNATs, G-N-A-T-S. It's a perfect mnemonic, has a silent letter in it. All right, so GNATS, right? So gentamicin, neomycin, amikacin, and tobramycin. Those guys are contraindicated with a patient that has risk for kidney disease. Okay, and then what else? So midodrine, that's our PO vasopressor, right? Can you start IV vasopressors? Absolutely, you can start those, right? But midodrine, we're gonna hit them up with, and you're also hit them up with albumin, right? So those are the two go-to agents, and then also we're going to contract all of their periphery, right? And we're gonna give a dose of octreotide. I thought it was on here. Maybe I skipped it, right? So octreotide as well. Okay, octreotide is going to cause splanchnic vasoconstriction, right? So splanchnic vasoconstriction is going to clamp down the portal hypertension, hopefully, and prevent fluid from going into the portal circulation, and therefore promote more blood flow to the kidneys. Okay, so midodrine is just a fancy. Which vasopressor is this? Where it's just an alpha-1 agonist, only binds to alpha-1 receptors and it vasoconstricts. It's pure. Which vasoconstrictor is that? Which vasopressor is that in IV form? Not vasopressin, but neosynephrine, right? Neosynephrine or phenylephrine, that's just pure alpha-1. Vasopressin does, yes, purely vasoconstrict, but it binds to vasopressin 1 receptors, right? Whereas alpha-1 agonism only is your phenylephrine, neosynephrine. All right, so what else? So dialysis is the end game. If we can't fix the underlying renal dysfunction, we might need to dialyze them. Okay, so this protocol right here is at Massachusetts General Hospital. It's their protocol. It's just for information. You can see that they're checking all the stuff, all the AKI things that could be happening. Is it pre-renal, intrarenal? What's the urine sodium? What's the urine osm? What are all these things? What's the is the shock corrected? And then eventually we are making sure the map is good. We get GI involved, and we're giving albumin. So albumin is our go-to agent, and then we're going to also give some octreotide in there. And what are we missing? We're missing midodrine, right? Norepinephrine vaso plus midodrine, right? Those are the goals. And then towards the end, that's where we start considering whether we do renal replacement therapy. And usually renal replacement therapy is only for those that are candidates for liver transplant. If they're over age 65, they are their MELD score, right? We talked about MELD score as well. That's the Matarese end-stage liver disease score, right? It looks to see if someone's a candidate or not for a liver transplant, right? I think 32 is basically like cutoff, like they're not, no, we can't do it. Mortality is way too high. We can't. You have all these other underlying problems. This unfortunately is not going to progress. Again, it's the GI doctor's decision, to get them placed and also to see if they can somewhat get them reversed, right? So a GI doctor is necessary for this, right? So you need a GI consult. Who else should be consulted here? So you got a GI consult, and who else? Nephro for sure, renal consult as well. So it's really renal's game. So when they get invited to the party, right? They go, oh, I know, and they're going to pull up with their Porsche. They're going to throw. They got the albumin bottles. They got midodrine tabs. They got octreotide injections. They're really going to go all out to try to resuscitate the kidneys as best they can. Okay, so albumin is used for this disease process, hepatorenal syndrome, which is a complication. It's also used for large volume paracenteses, and also used for SBP, right? So SBP as well. These are our 3 reasons for albumin for liver failure.